Bonsoir, mes amis. I'm so grateful to Olivier and Marc for inviting me to the lovely city of Paris in the spring. And so sad that I am still in Rochester to give you this talk, but I am delighted for the invitation. I do thank merci beaucoup, Marc and Olivier. And I thank you for allowing me to speak about the Freedom EV data. And I obviously present this on behalf of my colleagues whom you see named here. I do not have any personal financial interest and don't receive any personal payments from United Therapeutics. Obviously, the University of Rochester does receive money for our participation in research. As you know, the Freedom EV study was the fourth large global event-driven study in pulmonary arterial hypertension. The study has a few unique features. It's almost 700 patients and a much more homogeneous group. These patients were hopefully recently diagnosed and on a single therapy. The study was started in 2013 when oral monotherapy was certainly the standard around the world. And we randomized those patients in a one-to-one fashion in 150 centers from 23 countries around the world. Obviously, an event-driven study, and we counted until 205 events as our power calculations suggested. We planned to enroll somewhere between 600 and 800 patients, and as we achieved the 190th event, we started closing down enrollment. The primary endpoint was achieved, obviously, for death. Adjudicated hospitalization due to worsening pulmonary arterial hypertension had to be at least 24 hours, and these were obviously very carefully adjudicated to make sure they were really related to pulmonary hypertension or worsening RV failure. Inhaled or infused prostacyclin to start for worsening pulmonary hypertension or the disease progression, and this could be met in one of two ways, either the standard drop and walk of 15% and functional class change, or symptoms of worsening right heart failure, need to intensify diuretics, repeatedly modifications because of abdominal bloating, edema, that sort of thing. And that did end up playing a role. Unsatisfactory long-term clinical response is something you're familiar with from Ambition. Turns out that this was a very small number of events, and I won't talk about it anymore. Obviously, the secondary endpoints typical for all of our studies. I do want to point out that we had an a priori decision to do risk assessment in this study in our final statistical analysis plan that was submitted before unblinding. We decided to use the French non-invasive risk score because we thought that the data for that suggested that it would be treatment responsive. So this is the first study that had an a priori decision to do risk assessment before unblinding. In terms of who the patients were, it was a very typical group, 63% idiopathic or heritable, but a nice chunk, 26% with connective tissue disease, mostly scleroderma. Not surprisingly, it was almost 80% female. And on average, these patients were younger than in other studies, 45 years of age mean, and most of the patients, the vast majority, younger than 65 years of age. A very nice chunk from Asia and the South Pacific, as well as a good portion from Latin America, and this counts for the younger age. Most of these patients were functional class 2, and look at the walk, 405 meters median, 395 for a mean. So these patients were a well-compensated group. Again, we achieved our desire to have them early in their disease, 6 months since diagnosis. Again, no dual therapy in the study and no treatment naive, a homogeneous therapeutic background with most patients on a PDE5 and some on an endothelin receptor antagonist. In terms of dosing, you know that the Freedom C and Freedom C squared studies, the previous studies, were twice daily. This is a 3 times daily oral treprostinil dose, and that made dosing much easier for the patients. By week 24, most of the patients were at 3.5 milligrams 3 times daily. I'm sorry, the median dose was 3.5 milligrams 3 times daily by week 24. And you can see that the median dose was almost 5 milligrams 3 times daily by the end of the first year of study. So this is a at week 24, this means that the median dose was on average, was about 10.5 milligrams total per day. So much higher doses than we achieved in Freedom C and Freedom C squared. And we attribute that to the 3 times daily dose. The peak trough excursions are much smaller with 3 times a day, much larger with twice daily dosing. So we think that the side effect profile was better, and that's why we were able to achieve the higher doses. Those higher doses, we believe, did make a difference. Here's the statement that I meant to make. About 2/3 of patients were able to achieve 3 milligrams 3 times daily by week 24, and almost 3/4 were able to achieve that by a year. We had a priori hypothesized that that would be a dose that was associated with substantial clinical gains. This is the Kaplan-Meier plot for events, and as you can see, the oral treprostinil group was less likely to have events. That separation occurred already by week 12. You can see I'm not able to point for you. I'm disappointed about that, but you can see the group separation occurred early by week 12 and was sustained throughout the trial. The hazard ratio was reduced by 26%, and this was statistically significant. In terms of the kind of events that made up the endpoint, you can see that deaths were unusual and balanced in the randomized placebo-controlled phase. Hospitalization due to pulmonary hypertension, again, relatively infrequent and balanced between the groups. A few more patients needed infused or inhaled prostacyclin, but the vast majority of the events were in the disease progression, and that is where oral treprostinil was highly protective. You can see that disease progression events were much more likely in the placebo patients than they were in the oral treprostinil patients. In terms of what those disease progression events were, you can see they were about half and half. Remember that you either achieve the definition with a sustained decrease in walk. That decrease in walk had to be repeated. Either a sustained decrease in walk and worsening functional class, usually 2 to 3, sometimes 3 to 4, or decrease in walk, again, repeated on 2 occasions, and an adjudicated narrative that suggests recurrent right heart failure. So, intensified need for diuretics, more abdominal bloating, more edema, that sort of thing, which of course we deal with in clinical practice every day. In terms of things that we're very keen on in pulmonary hypertension these days that contribute to risk assessment, you can see that the group of oral treprostinil patients did appear to have a higher NT-proBNP at baseline. This just missed statistical significance, but it does look like the groups, in general, the oral treprostinil group was worse. I'm showing you median and 25% to 75 percentile interquartile. And by week 12, the shift is already readily apparent. The medians are better matched, and the 75th percentile has dropped so that the oral treprostinil group is much more tightly aligned. And by week 24, you can see a very clear visual difference, and that progresses out to week 36. So all of these differences highly statistically significant between the group. And I'm very encouraged by this because this suggests that, change in RV function, right? And that this is oral treprostinil early influencing RV function. In terms of functional class and symptoms, we saw favorable functional class shifts with oral treprostinil, and that was it could be seen in both an increase in the number of patients from week 4 to week 24 who improved their functional class, again, usually 3 to 2, but also a shift in the placebo patients worsening their functional class from 5% to 18% here. In terms of 6-minute walk distance, we did not hit a statistically significant benefit at week 24. I'll point out a couple of things. First of all, this was, at the time, the largest baseline 6-minute walk in pulmonary hypertension studies, 405 meters median, 395 meters mean, much higher than Ambition, for example, at 350 meters, much higher than Griffin similarly. So in this relatively homogeneous group of monotherapy patients recently diagnosed with a long baseline walk, at week 24, we did not achieve statistical significance. You can see that the placebo patients are still maintaining walk gains out at week 24. What you do see is that by week 12, there was a clear improvement in walk in the oral treprostinil treated patients, and that walk improvement is sustained. What happens at week 36 is the placebo patients start to fall off. This particular analysis is actually the observed case analysis. There's no imputation here. We're looking at real patients, which means that the clinical worsening events are not imputed here. These are the observed cases for patients who have not had clinical worsening, and yet we still see a clear statistical benefit by week 36 and sustained out at week 48. And the week 36 benefit is driven mainly by patients who improve, not by patients in the placebo group. The more traditional Hodges-Lehmann estimate, the analysis of covariance, non-parametric estimate here is shown, and it basically shows the same thing, which is that there is not a statistically significant difference at week 24, but there is at week 36 and week 48. So French non-invasive risk assessment of great interest to this group, of course, and we a priori decided that we would look at improvements in risk. So I expected to see improvements at risk at week 12 and week 24 and week 36 and beyond. What I did not expect to see was that at baseline, the groups would be so lopsided. So, a table 1 demographic at baseline, and obviously this is published now in the Blue Journal from last year, shows that each of the individual characteristics are well matched between the groups. But if you look at a multifaceted risk assessment, you see that the groups are not well matched. In fact, the oral treprostinil patients were much more likely to die at 1 year. And this was highly statistically significant and completely unexpected. We used a traditional randomization scheme, much like all of the studies to date used, and we found that the oral treprostinil patients were much more likely to have 0 low-risk factors and much less likely to have all 3 low-risk factors than the placebo patients. And of course, this made a big difference in the risk for events, right? So if we, again, this was an a priori decision to look at the French non-invasive risk. We didn't do this post hoc. What we did do post hoc is we analyzed the event data with the surprise finding that the risk groups were unbalanced at baseline. And when we did that, you see a much greater risk reduction. So now we have a 39% risk reduction, which is highly statistically significant and looks much more like the risk reductions from Seraphin and Griffin and Ambition, where we see much larger risk reductions than the 26% we initially reported. And again, I just want to point out that the only thing that's post hoc here was that we were surprised that the risk groups were imbalanced. We planned to do risk assessment. We just didn't expect that we would have to adjust the hazard ratio for the tremendous imbalance in risk. So if we plot that out in a Kaplan-Meier plot and we arbitrarily look at the higher risk 0 and 1 group versus the lower risk, those with 2 and 3 of the French non-invasive risks, you can see that both the higher risk and lower risk are visually different. There's more patients in the higher risk group, so that group was statistically significant. The lower risk group is a smaller number, and the group is not statistically significant, but the hazard ratio is similar for both groups, and it appears that there is a difference for both groups. In terms of the risk shift, we saw a statistically significant improvement in risk as early as week 12, and that continued on through week 60. And that, again, there's no imputation here. So that this is the risk shifts for patients who are still in the study and have not had clinical worsening. So again, you see that at week 12, there's already a worsening of risk in the placebo patients, even for those who haven't had events. Obviously, there's a lot of adverse effects for prostacyclin class medications. Not surprisingly, you all use treprostinil infusion as Remodulin. Headache, diarrhea, flushing, nausea, you're not surprised to see. I would point out that a lot of our patients have headache and nausea and diarrhea in the placebo group, and to remember that these are sick patients, but no question, oral treprostinil is not for everybody. 19% of oral treprostinil patients dropped out because of adverse events. And finally, and I think very intriguingly, this is we planned to assess vital status as part of our statistical analysis plan. This was not post hoc. Unfortunately, we did not plan to do vital status assessment until the study had already begun. It was clear to us when Ambition got published in 2015 that we needed to do this. So we made a plan to start assessing vital status, but many patients had already dropped out. The data I'm showing you is for 90% of the initial participants for whom we were able to collect data on. And you can see that by the end of study closure, so by the end of the randomized study, by the end of the open label phase, and then when we follow up people after they've dropped out of the study, when we continue to check vital status on them, we have most people accounted for, and we have statistically significant difference in the deaths, 60 deaths in placebo by study closure versus 38. And this is statistically significant, the hazard ratio showing a 37% reduction in the likelihood for death. I'll point out that even if we assume that among the unknowns there are 5 excess deaths in oral treprostinil, we're still statistically significant. And one final word, remember that the oral treprostinil patients started out with a higher risk for death, right? The French non-invasive risk score predicted a higher risk for death. If we adjust for that, we have a 42% reduction in the hazard risk for death, even more statistically significant. So, and again, this is this sensitivity analysis that assumes some excess deaths in oral treprostinil among the unknowns still shows this. So, how does this compare to Freedom C and Freedom C squared? You see that the oral treprostinil doses at week 12 are higher for Freedom EV. At week 16, they're higher. The total daily dose is higher. And by week 24, obviously much higher. And I'm going to skip over this last for time and just summarize my findings. There's a 26% risk reduction in clinical worsening driven by disease progression. When we adjust for the tremendous increase in baseline risk, this becomes a 39% risk reduction. And I'll point out that, again, this was post hoc only because we did not intend for the imbalance. We did intend to look at risk. There was a significant improvement in risk, and we had pre-specified that analysis in our plan. Adverse effects are common and resulted in 19% of the patients dropping out in the oral treprostinil group. I strongly believe that future studies should randomize participants, and I point out that REVEAL 2.0 or REVEAL 2.0 Lite might work just as well as the French non-invasive in terms of a basis for randomization, and that the French non-invasive risk score was treatment responsive. This is the first study in which there was an a priori plan to look at the French non-invasive risk score and determine whether it was treatment responsive. It clearly was. So congratulations to my French colleagues for their foundational work in looking at risk. And I'm so grateful for the opportunity to have presented today. Thanks to all the Freedom EV investigators that I quickly scroll through here, especially my colleagues in France. Thank you very much.